that this is the main focus for us. It is also a factor about a health system, but not only the health system. It is all our member societies in all our countries. And if you dive deeper here in your country, what is the specific reason for a maternal mortality rate in all your provinces? So that is why I'm so pleased that all the governors are that much committed to exactly this topic. We have to understand that we need more knowledge, we have to do more research if we really want to change a maternal mortality rate. It is not just to educate, because you all here in the room are well educated. You know everything, and you have, every one of you has read the guidelines, so you are aware, but we have to focus on all these factors. So thank you so much that you give me the opportunity to witness what you are doing here in your country, and please allow me to adopt your policy to all other countries on earth. Thank you so much.
Thank you very much. Bold statement, considering that you have 142 countries that will need to adopt the policies that we are speaking about now. Thank you very much, Professor Lowen. Next, to give the keynote address is Mary Mwiti. She's the Chief Executive Officer of the Council of Governors. She's a corporate governance professional with industry experience spanning over 20 years of progressive service in high-level systems and services leadership in different administrative functions. Karibu sana Mweri, the floor is yours.
Thank you very much, and good afternoon.
Good afternoon.
Good afternoon.
Good afternoon.
Your Excellency, the Governor for Makueni, Governor 01 in his Mpdsr initiative, the President of FIGO, Ministry officials, county officials that are present, development partners are present, ladies and gentlemen. Allow me first to acknowledge that the person that is standing before you is a survivor of what Mercy asked us to raise our hands about. I am a survivor of PPH, and for that reason, Mpdsr started a long time ago, and that's why this lady that is standing here is actually here today. I have shared a story with all the Mpdsr champions, and I know they are here. And number two, Your Excellency, I am extremely excited today, looking at this logo that is above there. This is our newest birth, newborn, inter-county Mpdsr initiatives. As of Mpdsr champions in the house, say hi. Are you happy about our new kid? Yes, thank you very much. Allow me say that it's a great honor to join you at this conference convened under the theme, Accelerating Mpdsr Response, Leadership and Governance in Ending Preventable Maternal and Perinatal Deaths. This conversation brings together the political leadership, clinical expertise, and policy commitment that are essential to drive meaningful change. Kenya continues to face unacceptably very high maternal deaths and newborn mortalities above the Sustainable Development Goal that I may not need to read because the people seated here are actually experts in the same. Behind every statistics is a woman whose life was cut short. I thank God that I'm a survivor today, and I'm here to partake of this and walk this journey, and that's why I'm intentional and deliberate about Mpdsr initiatives. A newborn who has never had a chance to thrive, and a family left grieving. And that's why we are here, so that we don't just read statistics as numbers. We know that every statistics represents a mother or a new. And a significant share of perinatal deaths are extremely preventable. Seated here are here so that we can have a candid conversation about the same. Maternal and perinatal death surveillance response is central to this effect. Mpdsr is more than a clinical review process. It is a leadership tool, and that's why we themed it governance and leadership, so that we can undertake the process review. It exposes system failures, strengthens accountability, and allows counties to act on real data, not assumptions. Since devolution, counties have expanded maternal health infrastructure, invested in skilled staff, strengthened emergency obstetric and newborn care, and integrated Mpdsr in planning processes. Some counties that conduct regular reviews have recorded reduced periods of 0 maternal deaths, demonstrating what strong governance and commitment teams can achieve. I want to say that across all the 47 counties, Your Excellency, and you are aware about this, we have activated the Mpdsr activities and initiatives every week. Initially, there are counties that will do reviews every month or quarterly, and Dr. Bashir in his opening remarks has told us it's not just about review without action. It is review that is tangible and the like. So I want to confirm to people seated here that the Council of Governors has taken initiative in ensuring that we activate the initiatives in all the 47 counties where they review the near misses and, of course, update and take stock of what is happening in each and every county. Discussion about this is followed by implementation across the 47 counties, and the COG has taken lead in ensuring that we communicate the resolutions that have been arrived by all the reviews on Tuesdays and Thursdays, so that we live not only on a rhetoric platform, but on an actionable platform that delivers this. Mpdsr is not a new thing. It has been there, and Dr. Bashir has told us they started this initiative in 2011, and I tend to believe this is the time that the conversation is live. And I cannot be more happy than today, because 3 years ago, we had a conversation, and I want to acknowledge Dr. Maina, Mary Maina. Where are you, Dr. Mary Maina? I want to acknowledge Dr. Mengo. Where are you, Dr. James? And all the Mpdsr champions. Where are the Mpdsr champions in this room? Please, wherever you are, stand so that we acknowledge you. We started over a cup of coffee, tea, Your Excellency, where we thought that, thank you, hata daktari ya wanawake amesimama hapa. Thank you very much. We started over a cup of tea, and this is what actually it has blossomed to be. We are extremely very happy that the reality has finally come home. Let's continue championing this cause, because we've said it's not a cause, it is a reality. And together, we will be able to achieve this. Across Kenya, we see clear county-level progress. National data confirms that 39 out of 47 counties have experienced decline in maternal mortality, and this is because of the initiative that each of the persons seated here has taken, to ensure that we reduce this. I pray that we continue doing the same and ensure that these improvements show what is possible when Mpdsr is consistently implemented. So we have to live by what we committed ourselves to do, and I keep on telling Katra that please keep on forwarding the clip that we committed in Uganda, that we will end maternal and newborn deaths in this country. We must, however, acknowledge persistent challenges, because this is not without challenges. Counties continue to face financial constraints, workforce shortages. This is why His Excellency the Governor is here, and myself, so that we take the resolutions from this conference back to the counties, especially specialists and uneven referral pathways that delay critical care. Your Excellency, these are some of the things that we need, systemic issues that we need to address moving forward. The transition to the SHA system has, of course, disrupted the access to vulnerable groups, while slow digitization and delayed claim strained facilities financially. And that's why the Ministry of Health is here, so that we see how the claim reimbursement is effective, so that we don't suffer, outstocks and the like as we move towards this. To accelerate, Mpdsr must be elevated from a technical activity to a leadership priority. This requires empowering county Mpdsr committees, ensuring timely implementation of action points, and institutionalizing a learning, not punitive culture. Strengthened inter-county collaboration is equally important for addressing referral-related maternal and perinatal death. This is what COG is committed to do, and this is what we do up to now. Our partnership with the Kenya Obstetric and Gynecological Society remains vital. The expertise, mentorship, and clinical leadership of Kogs are essential in standardizing quality, strengthening adherence to protocols, and fostering continuous improvement. As I conclude, our commitment must be clear: prioritize maternal and newborn health in county budgets, strengthen human resources, improve facility readiness, including a stocking of our commodities, advance digitization, support community health systems, and ensure that every review leads to action. Every review leads to action. Ending preventable maternal and perinatal deaths is within reach. What it requires is bold leadership, coordinated governance, and unwavering commitment by each and every person that is represented here and the country at large. Allow me to stop at that so that we can appreciate the pathway that we all commit to progress moving from here. I have said again, we have committed ourselves severally. We have a Mpdsr dashboard that is active at the Council of Governors that takes stock of each and every county in terms of the mothers that we are losing, the near misses are recorded, and the like. So let's ensure that we partake of this conversation together. Asanteni sana.
Thank you very much, Mary Mwiti, Miss Mary Mwiti. Let's give her a warmer round of applause. And it's good to see the commitment of, the county leadership on Mpdsr and being able to address this and committing that no mother, no child should die of preventable causes. That is very strong and we appreciate that. So to move next, that was a good segue into the next, where we want to see practical examples from 3 counties. We'll go to Kisumu, come back to Kilifi, then go to Murang'a, where we want to hear from Kisumu, that is Dr. Greg Ganda, who's an obstetrician, the CEC Kisumu County, and also the chair of the CEC Kogs, the Council of Governors, who will present Mpdsr as a leadership, governance, and quality of care agenda, followed by Kilifi County, Dr. Mitei Chepwagen, who will present about emergency referral pathways, and then Dr. Grace Wanjiko, who will present about county innovations. So we start from Kisumu, Dr. Ganda. Let's appreciate him as he walks to the podium. We get to hear Mpdsr as a leadership and governance quality of care agenda.
Good afternoon, everyone. Good afternoon. Yeah, I see you're still awake. First of all, today I'll not be speaking about Kisumu. Today I'll be speaking on behalf of all the county governments in my capacity as the chair of the caucus. So I will be a curtain raiser. I'm used to coming to Kogs as a presenter, talking about P values, but today I'll just be a curtain raiser for the real people who are going to speak to you and tell you what's really going on in the counties. So as I start, I just want us to reflect that somewhere in Kenya today, one woman will die trying to give birth, trying to have a baby. And the thing is, one of us in this room could have saved her. I want that to reflect. Today, somebody is going to die trying to get a baby, and one of us in this room could have saved her. So the question is not the skill, but whether our systems allow that skill to reach her on time. You might be on the table and you want more blood and it is not there. That skill of yours doesn't help. There might be a nurse who has PPH in the lowest level, but she doesn't know what to do. You did not mentor her. So it's a whole system, that the system work for them. So my reflection is that every preventable maternal and neonatal death is a governance failure before it becomes a clinical one. And why is that so? Why that is so is because the death signifies a system failure. A woman dies because blood failed. And blood is a whole system, from getting it from somebody's hand, from transporting it, to storing it, to doing the GXM, to getting it next to the patient. Who is in charge of that system? The referral failed. Theater failed. You wanted to operate and then you are told the drapes are not ready. The staffing failed. Yes, the staffing failed. You have this person, he never comes when he's called, and so he comes late. Who failed her? Administration failed her. We tolerated it. We knew this person always does this, but we tolerated it. And so today, somebody has died. And then oversight failed. The person who is in charge of that other person also saw it. And so because you did not oversight, we failed. So the system failure is a leadership failure. It is leadership that aligns the systems. Otherwise, the systems fail the patient. So this is COG's flagship agenda. The Council of Governors is positioning Mpdsr as a national leadership priority and not just a program. And that makes Mpdsr a leadership instrument at all levels, even if you're in charge of the ward, even if you're the president, all right? You use this to detect, act, and prevent that recurrence. And so the inter-county Mpdsr initiative is county-led, peer-to-peer learning, and an accountable system anchored at the COG that connects the frontline health workers in all the 47 counties, the national referral hospital, the county, and the national leadership. So everyone under one platform to be able to share. So we know health services are devolved, but the patients never got devolved at any one point. They move from facility A to facility B to facility C, a national hospital, a county hospital, a private hospital. But then, over time, all of us in this room have learned that when you deliver that baby and the baby cries, you are not the hero. There's somebody who made sure that that instrument is sterile. There's somebody who did this, so much that goes on around. Starting from the lowest level, the nurse who did the antenatal clinic, and all those people. So already, we are sharing clinical responsibility. That good outcome, we share it, all of us. That bad outcome, we also share it, all of us. So now, why don't we share the learnings? And that is what Mpdsr is all about. This is what the inter-county Mpdsr is all about. We want to learn from each other so that the mistake made in Kisumu should not be done in Mombasa. And so we are facilitating rapid sharing and scaling of best practices across countries. For example, Nyeri's daily report and Kiambu's preeclampsia SOPs. So there are risks to this. We will expose workforce gaps, referral delays, blood shortages, all this will be exposed. And at some point, somebody will get uncomfortable. And that is the storm that we have to weather. In such a point, I remember in Homa Bay, when the ambulance did not have fuel, but Homa Bay was able to share this with the whole country, that this lady died or almost died because there was no fuel. That is the learning. We accept this was a failure, we are fixing it, but we want all of you to learn. And now when you hear Shai saying they're dealing with ambulances, it is from these learnings. So, adoption is no longer the question, it is execution. 37 counties already doing weekly reviews. National webinars. Last time we had a webinar on maternal death due to anesthetic causes. It was realized that it's happening in many counties. One webinar, policy effect. Shared dashboards, which are counties can use to share from each other. Escalating MCH priorities, and many more. And so the COG will support from development partners, has developed also an investment case out of these. So there are many gaps, of course. The response, reviews happen, but there are no named owners, no timelines, no escalations. Specialists are absent. Sometimes there's blame culture, underreporting, defensive documentation, and disengagement. And specialist disengagement, you know, it goes on. That's a thing for nurses and junior people. And finally, what I think is one of the most important things, failing to weather the storm. When those uncomfortable things are said, when those uncomfortable things are exposed, instead of dealing with it, you run under and you run away. You stop reporting, you stop coming for the meeting, and all that kind of thing. So I want to end by what the consultant role is. Mpdsr should be consultant-led. It is a clinical standard. Clinical standards cannot be delegated. I mean, the specialists must lead the clinical standards. When you are present, it signifies a seriousness. If there's a meeting where 10 consultants are in that meeting, it's a serious meeting. But then, your participation, when you say this should be done like this, I don't think you start shaping a culture. And that is what we want to do. Now, what leadership does is prevent that recurrence. Leadership from you and leadership from all of us. So COG and all of us, when I take my other hat as the caucus chair, I become COG, will enable counties and clinicians to succeed by convening cross-country learning, strengthening governance protection, supporting data visibility, aligning leadership with frontline realities, and driving investment towards high-impact gaps. 48 governments, one nation. I want to call in my two colleagues who will be introduced later, who will share various experiences from different counties. One county which is vast, Kilifi is vast, with several problems, challenges, roads and all that. And then another county which is smaller but has different challenges. Thank you very much.
Thank you very much, Dr. Ganda, for your presentation. The take-home being, this is a governance issue before it's a clinical matter. Now let's hear from Dr. Mitei, Kilifi County.
Greetings, colleagues. I'm going to give you a Kilifi experience addressing the second failure that Dr. Ganda has talked about as one of the system failures. So the referral system. As Kilifi, we've tried to optimize maternal outcomes through leadership-driven Mpdsr and emergency referral systems. If you look at that thermometer, the red is the highest temperature, and this is the time we had the highest mortality ratio recorded. That is between July 2021 and June 2022. And the green represents when we had the lowest mortality ratio between June 2022 and June 2023. Now, in terms of facility MMR trend, we were doing very well between the year 2021 to 2024. You're wondering why it's changing to go up from 2024 and 2025. And I would like to make that clear for you. It's because we became very robust and audited all cases, going all the way down to the communities. That is doing verbal autopsies. Now, from August last year, we've been doing weekly Mpdsrs, and we've come up with gaps that address the maternal deaths and some of the gaps that address the perinatal deaths. When it comes to the maternal gaps, we have documentation as one of the gaps, ICU and HDU capacity, post-CS monitoring, blood commodities. If you attended our 3 last CMEs of Kilifi County, you must have realized we were working very hard to make sure that our ICU is capacitated, and we are hoping to have an ACLS training to address that. For perinatal mortalities, we picked up gaps as poor documentation again, delay in care, and weak referral coordination. What are the best practices that we've picked since August last year when we began doing this Mpdsr very, very seriously? First of all, we were able to do maternal death review compliance at 100%. I was hoping for a higher clap. And as the Kilifi County and Referral Hospital, every Thursday, faithfully, they don't leave the baby behind. Remember, we were guilty of not doing perinatal audits. Now the Kilifi County and Referral Hospital is doing that every Thursday. The reason they began is we are all sending our babies to them because they are the ones who have our NICU. They are hosting our NICU. Bubble CPAP, it was a low-cost innovation, but it's now happening at the sub-county level. Now, from that also, we were able to pick what do we want to prioritize from the gaps that we've noticed. One of them is a 24-hour rapid response for PPH and eclampsia, because we noted that to be the leading causes of death for our mothers. Making sure we have functional equipment, both in the ward and theater. That includes a functional BP machine, a pulse oximetry, PPH bundle, NAS-G, close gaps that delay decisions and treatment. Also, an ICU and HDU surge plan at referral hubs, that is Kilifi and Malindi. And then we are hoping to ring-fence blood supply. I'll mention how we are doing that in the next slide. And continuous observation using the Muse chart, post-delivery, and for all our post-CS patients. Now, addressing the system of referral. As Kilifi County, we were able to come up with an emergency service cycle that we have ambulances dispatched at different sub-counties. Like Dr. Ganda mentioned, our county is very vast. So we have a one operator referral center that is called when you need help. They dispatch an ambulance using a tracking system. If I'm calling from Twapa, they can tell which ambulance is close to me, and it's dispatched. Then we have an EMT team that was trained on ACLS, and they are able to now accompany the patient to the center where we are referring this patient. This addressed the capacity gaps. Initially, we used to have nurses leaving the hospital to escort the patient. But now we are having this team handle that. But we are not saying we've entirely replaced other cadres taking our patients during referrals. For any patient that requires a nurse, a doctor, even an anesthetist, we do that together with the EMT team. How have we been able to sustain this? Through funding and partnerships, resource expansion, capacity building, dispatching optimization, resource decentralization, and also monitoring. I've explained that in the previous slide. Now, we came up with a dedicated ambulance for only the mothers and the babies, and it looks like that. So it will not be used for any other case except the mother and the baby. If you're tempted to clap, please clap. Thank you. I'd mentioned the first 3 points, but I'm going to just mention the fourth one. We were able to do a bottom-up reporting with county validation and action tracking. That means going from the community to the facility to the sub-county and then the county. Some of the other things we were able to do, you might have seen some on the newspaper. We involved the County Assembly Committee on Health, which saw the department finalize the County Reproductive, Maternal, and Newborn Adolescent Health that was gazetted into an act by the County Assembly of Kilifi. Through our Waziri, we were able to meet in the past year, come up with obstetric SOPs, of course, while adhering to the national guidelines. So even as yesterday, we were having that launched. We had done that for our symposium last year, in December. Then, to improve maternal and perinatal outcomes, this weekend that just passed, Saturday, the Malindi Sub-County Hospital has now moved to the newly constructed and well-equipped unit that hosts the newborn and maternity. And the Kilifi County and Referral Hospital is being facelifted to accommodate even more and address more gaps. The county, through the COG and Proximi, we are moving towards telementorship so that we don't spend so much money to go down on the ground and teach these skills. The infrastructure was set up, if I'm not wrong, 2 weeks ago, and we are hoping to start using that as soon as possible. Now we have a competition in different sub-counties. We've challenged ourselves that every sub-county shall be collecting blood whenever they have resources possible. And before I show my last slide, allow me to thank our Waziri, Peter Mworogo. He's been very supportive. He picks our calls. Sometimes I feel like I misuse him because I use him as my debrief and tell him what problems I'm having. He's never refused to pick my call. He's never refused to answer my text. Please, Waziri, just stand and raise your hand. Thank you so much. And finally, lives are saved when accountability meets action. That's my parting shot. Thank you so much.
Thank you very much, Daktari, and thank you for the case of Kilifi County. That's commendable. Let's appreciate Kilifi County and the leadership of Kilifi County. Next, let's hear from Murang'a County, Dr. Grace Wanjiku, about the innovations that are practical and scalable. You have like 7 minutes.
Greetings from the county in the mountain, Murega. How are you all doing? So my name is Dr. Grace Wanjiku. I will take you through some of the innovations that we are implementing in Murang'a County. This is misbehaving a little. So we are one of the counties that has been able to implement the Mpdsr process for quite a long time. And we started our weekly Mpdsr meetings about 1 year and 4 months ago, and a lot has come out of it. So I am here to share with you practical and scalable county innovations in MNH, strengthening commodity availability and leveraging digitalization. So our county had about, in the year 2025, about 18,000 deliveries, and we had about 26 maternal mortalities, which brings us to a facility-based maternal mortality rate of about 144. That is supposed to read 144. And we have realized that reliable commodity availability is a key determinant of positive outcomes. And some of the other governance issues that are driving positive outcomes is we are blessed with a very responsive leadership. Right from the County Governor, His Excellency Irungo Kangata, and the leadership that is in charge of the health department, including our chief officer, Bwana Isaac Karoga, who is here with us. He came to support us. We have a very responsive leadership when it comes to maternal and newborn health issues. We have an active Mpdsr team that is led by the gynecologist that does supportive supervision in all the facilities in the county, including verbal autopsies down to the community. In the year 2025, we had 3 of them, and we were able to identify the issues that led to maternal mortalities in the community. We also have a highly interconnected HMIS system that enables digitized reporting and stock management. We have critical commodity forecasting, which is strengthened through data, and this has been done by our procurement department and also the pharmacy department. They are able to forecast and be able to order commodities, both critical and essential commodities for MNH on a quarterly basis, and therefore we always have enough stocks. And even when we do not have enough stocks, we have collaborations with the local players, the pharmacies in the local area, so that if you have an acute shortage, then they are able to quickly call in a private player to provide for it. One of the very successful interventions that we have been able to implement in Murang'a County is the County Blood and Blood Product Network, which was actioned by our County Director of Health, Dr. Mburu, and we have been able to bring together all transfusing facilities in the county, be it private, faith-based, or public facilities. We have come together to form a caucus that is able to support blood drives. So from June last year, we have not had any major issues when it comes to shortages of blood. The only main challenges that we have with blood is when we have issues to do with screening from our regional centers. So we coordinate real-time blood needs from our WhatsApp group, just our WhatsApp platform. I can tell you even right now, there's somebody asking for blood somewhere and there's somebody responding very quickly, and there's a rapid transport arrangement for blood needs. So this issue of bringing transfusing facilities together has really reduced issues arising from blood unavailability. And this came from, I think it was 2024, when we had a number of maternal mortalities arising from unavailability of blood. And we came together as a county and realized we have to do something about it, and it has succeeded. So I think I have spoken about this, the responsiveness of the leadership, the facility administration leadership, continuous medical education, a very active EMOC mentorship program down to the lower level facilities. Another success has been adoption of use of calibrated drips and the e-motive bundle for prevention of PPH. And I can tell you, like in my facility in Murang'a County Referral Hospital, for the last 6 months, actually 7 months today, we have not had a maternal mortality arising from PPH just because of this. Thank you very much. So as I said, we have partnerships with private faith-based facilities for emergencies during acute shortages. So what is our call to actions for us as colleagues? We need to be present in our places of work. We need to offer mentorship. We need to attend and chair Mpdsr meetings in our facilities. And if your county has started the weekly Mpdsr meetings that were actioned by the COG, please attend those meetings. Standardize care. Lead in adoption and adherence of evidence-based standard operating procedure. A good example is what is happening in Kiambu. They now have an SOP for PET and preeclampsia and an SOP for management of PPH, which we always borrow from them. So SOPs for obstetric emergencies and auditing compliance as per the MOH guidelines. Take leadership, strengthen referral governance, agree on a minimum referral standard. For us as a county, we agreed as gynecologists, the 5-6 gynecologists that are in Murang'a County, that if you are in a lower level facility and you have a PPH patient, you will not refer that patient to the next level until you close the tap. The tap has to be closed before you refer. Stabilization checklists, feedback loops between sending and receiving facilities in your county so that we can learn from each other. Thank you very much.
Thank you.
That is the end of my presentation.
Thank you very much, Dr. Grace, and thank you for the call to action. I was expecting a bit of a heartier clap when you said we should be present as colleagues in our facilities and that we should attend the Mpdsr meetings. I thought it would be more hearty even with a standing ovation. Thank you very much. Next, I want us to watch a short video on the Mpdsr, an Mpdsr documentary, just very briefly, and then we'll go to the panel session. And then if you can switch off the light so that the video is more visible, I think that would be ideal. And my panelists kindly take the stage for the next session. Santeni.
Newborns lost every single day. These are not just numbers, they represent devastated families, future generations, and lives tragically cut short, lives that in some cases could have been saved.
The arrival of a baby in African culture is normally a celebration. The issue of mothers going to delivery units or hospitals when they're expectant is one that is supposed to be met with celebration, not an anticipation of loss of life.
But if there was a way to reduce preventable maternal and neonatal deaths, but if we could protect the lives of both the mother and child during pregnancy and childbirth.
It all started with a conversation on the table where we thought that we could go and learn some of the best practices in other counties and other jurisdictions on how they've been able to bring down maternal deaths and, of course, their child mortality rates down.
A group of obstetricians and pediatricians
came together and said we need to be innovative in how we implement Mpdsr in the county so that we can start seeing a drop in the number of mothers and women who are dying.
The Inter-County Maternal and Perinatal Death Surveillance and Response Initiative is changing this narrative one life at a time.
This initiative brings together like-minded healthcare professionals, advocates, and all who are interested in bringing down maternal and newborn health.
Mpdsr lies exactly as a structure under the county government's health function, and that's what we thought as the Council of Governors. We need to take this Mpdsr project extremely very, very critical.
What we intend to be able to do in that is to showcase the issues that are there, go through the figures, crunch the numbers, what is causing maternal death and perinatal issues, and what we can be able to do.
This initiative is an innovative, collaborative process among Kenya's county governments aimed at ending preventable maternal and newborn deaths by strengthening implementation of the maternal perinatal death surveillance and response system. This is done through data, shared learning, accountability, and collective action.
We have actually a platform of consultation between all the 47 county governments. Our strategy basically is to ensure that inter-county Mpdsr is implemented in all the 47 county governments. We want all mothers who are actually pregnant and we lost them be audited within the first 24 hours so that we know where we've missed a gap, so that we can be able to address that.
Founded and championed by frontline healthcare workers drawn from different counties, this initiative is anchored under the Council of Governors, COG, and implemented in partnership with the Ministry of Health and key development partners. Through Mpdsr, counties undertake periodic reviews, identify common challenges, share best practices, generate actionable recommendations, and implement targeted interventions.
For the counties that do not have specialists, our inter-county Mpdsr specialists are willing to go to those counties and mentor the young nurses and also the doctors who are upcoming.
From strengthening referral systems and sharing cost life-saving resources to reduce maternal mortality, county governments have achieved notable milestones in strengthening primary healthcare systems and enhancing maternal and neonatal health, the challenges notwithstanding.
One of the successes that I want to confirm is we have very many counties, 6 to 7 months without any maternal death as a result of this initiative that we took as the Council of Governors.
Nilikuwa na miscarriage 9, lakini saa hiyo mnisaidia, niko na mtoto wa 2. Penye nilipelekwa theater nilitolewa mtoto akiwa na 33 weeks na alikuwa na 900 grams, na kutoka pale madaktari wamenisaidia juu mtoto alikuanga on off damu na isha, wanaweka ingine inaisha, wanaweka ingine, na kucha ameenda tena wanajaribu, anarudi ako sawa, lakini nilifurahi. Nilikuwa tu pia mimi naomba sasa mtoto wangu ako sawa, kutoka 900 grams sasa yako 1930.
Inter-County Maternal and Perinatal Death Surveillance and Response Initiative demonstrates that when counties work together, progress is not only faster but also more sustainable. Through the concerted efforts of all stakeholders, we can accelerate progress towards reducing preventable maternal and newborn deaths and achieving UHC. Let us collaborate meaningfully and innovate boldly to ensure that every mother and every newborn not only survives but also thrives.
We need the support of everyone, especially the development partners, input from the Ministry of everyone else, and with that we can be able to get it done.
Let us all join hands together, and we are happy with the inter-county efforts to share the experiences and expertise so that we can be able to reduce this problem.
We are asking the country to support this initiative so that we are able to reduce the number of mothers and newborns that we are losing in our country. We can share ideas, we can share data, we can come up with strategies to ensure that every newborn not only survives but thrives.
Our mantra is to ensure that there is no mother that loses life while giving life, and there is no child whose life is cut short as a result of the mother giving birth.
The Council of Governors brings you the Inter-County Maternal and Perinatal Death Surveillance and Response Initiative.
Excellent. Thank you very much. And thank you for the good work that COG, Ms. Mary, and your team, and the team of the doctors, the co-founders of this initiative that have been able to achieve and have such excellent stories from the mothers. Now, next allow me to introduce our panelists. My panelists are to my left. I always have to try which one writes. To my left, and I'll start with His Excellency Mutula Kilonzo Jr., who is the governor of Makueni County, previously the senator for Makueni County between 2013 and 2022. He's a strong advocate and champion for maternal health and improved health outcomes. He is Kogs Honorary Member 001. Dr. Kiriki, I hope I got that right. Your Excellency, Kogs Honorary Member 001, let's give him a round of applause. To his left is Dr. Serem. Dr. Serem is in charge of, okay, just give me a minute. Itilafu ya mitambo. Dr. Serem, Edward Serem, is at the Ministry of Health, the head of Division of Reproductive, Maternal, Newborn, Child and Adolescent Health, and also an obstetrician gynecologist, and he'll be speaking on his capacity from the Ministry of Health. To his right is Dr. Kevin Osuri. Dr. Osuri is the Chief Officer for Health in Homa Bay County and the Chair of the Chief Officers of Health Caucus, a role that positions him at the center of inter-county technical coordination and peer leadership within the devolved health system, and we'll be able to get to hear from him more from Makueni County. And then next to Dr. Serem is Dr. Karen Muthembwa, who is an obstetrician gynecologist based in Laikipia County, specifically in Nanyuki, and committed to maternal and newborn health. She's an advocate and a champion for Mpdsr. Next to Dr. Muthembwa is Christine Sami. Christine Sami is from Kitui County, a nurse with over 29 years of experience as a nurse midwife and also the RAMCA coordinator in Kitui County, a champion for Mpdsr. We'll get to hear from her and her experience from Kitui County. Next to Dr. Osuri is Dina Haemba from Bungoma County. She's the maternity unit in charge at Bungoma Teaching and County Referral Hospital, where she coordinates maternal and neonatal health services. Last but not least is a pediatrician, Dr. Edith Mwasi, a neonatologist, passionate about giving neonatal quality health care and decreasing morbidity and mortality for neonates in Kwale County. Welcome, karibuni sana, my panelists, and I'll start with His Excellency Mutula Kilonzo from, speaking on behalf of all the other governors, on your own behalf from Makueni County. First of all, we start with the recent report. You have an unmodified audit report. In my financial language, I'm thinking unqualified audit opinion, which is quite commendable. And here we are talking about leadership and governance being a key part of, saving mothers. So how do you do this?
Thank you. Good afternoon, all of you. Thank you for inviting me again, Kogs, and for honoring myself as honorary member number 1 and my wife as honorary member number 2. When I was requested to champion PPH, I didn't know what I was getting myself into. After the meeting in Cape Town with the president and the former president, Dr. Kihara, Professor Kihara, is when I got into Mpdsr to listen into the conversations. I was not prepared for what I got to hear every Thursday morning. I missed the session this morning because I was on transit to Mombasa. It takes a lot as just a governor to listen in into the conversations about the things that are going on, the peer reviews among doctors, what went wrong, what was supposed to happen. But like in the Bible where they say that you shall know the truth and the truth shall set you free, in my case it doesn't set me free. It has bound me to many things. It has helped us make very private decisions about what requires to be done, where we need to help the doctors, where we need to help the specialists, what needs to be done. And I sit at the forefront to ensure that those things that we have agreed are complied with. I have 4 cases, and I'll mention them quickly. I have a lady who had excessive bleeding, was at home with a teenager, was moved to a hospital. The hospital didn't have an anesthetic machine. They checked, they said she had a child, she was moved, and I was following. And I was breaking into sweat, wondering about this young lady. She bled a lot. But we learned that in the facility where we needed to have a machine was purchased immediately. We saved that lady. Number 2, I get to hear the cases, like in one case where this mother went for ANC, they checked everything, but somebody missed checking pressure, and she had developed pressure. So during delivery and after delivery, she had excessive bleeding. I have a 4th case, recent, maybe a week or less. A mother was brought to the hospital. I think, I'm not sure, but the baby passed on somewhere in between. She was in hospital and had refused to have surgery. And the process took an hour. 1 hour. So it was near death situation. I went to see the lady to understand what she was thinking. And the doctors took action. The 4th case and 5th case is, I have 3 cases, 2 cases of young children born recently with hydrocephalus. I hope I've pronounced it correctly. Operated on, and they have a tube running from their head to their stomach currently. It's part of sitting in these meetings that helps us equip our hospitals in having the best person in charge and an anesthetist around, etc., etc. The 5th one is we have a baby who is about 840 grams or so, born 6 months, after 6 months, and she's doing well. This has helped in terms of making sure that we are equipped. When I speak to partners, the partners who we have in Makueni, I know what I am asking for. When I say I need a CVAP machine, I know what I'm talking about. When I say I need an intrusive ventilator for the kids, I know what I am talking about. So when this good team that is here, led by Waziri Joyce, who is here, Dr. Mwatha, who is in charge of the response in terms of the recommendations we make in the Mpdsr meetings, and CEO Harvey, who is also a pharmacist. When they talk about caffeine, is it citrate or nitrate? It's which one? Citrate. That one. I know what I'm saying and why it is required. When I hear that KEMSA has run out of its tebocabetocin, I wonder, what are these people talking about? So what am I saying? If every leader in this country sat in a minimum of 1 Mpdsr meeting, things would change. They would appreciate the work that you have to go through. They would appreciate the assistance we require, and they would appreciate the sort of resources we need to put in to ensure that you have a good referral system, you have a blood bank like the one I have in Makueni, you can move the blood quickly, you can transfuse quickly, you have an ambulatory system, you have a gynecologist quickly, you have an obstetric fistula surgeon, those sort of things. Without government involvement, and I said this in Figo, the only problem about these meetings, you have doctors sitting here and others sitting here, and you're talking to yourselves. And the people who need to make legislative decisions, financial decisions, budgets, etc., are not here. I would have been pleased to hear from the cabinet decision last week about budget that we have set aside X amount of billions of shillings to take care of mothers and neonatals. That I would have known we are making progress in terms of ensuring that we are 355, we are less than 355 over 100,000 live births, or 19,000 or 900 for the case of neonatals. We are not doing enough, and it's because the leaders are not getting involved, and I'm pleased to learn and thank the team from the Council of Governors, led by Director, led by CEO, for ensuring that the governors of Kenya are sitting in the meetings. And since we are not looking for fault, as Dr. Bashir is saying, we are trying to find best practices. What do we refer? We had a case of rhesus factor. I'm still learning, by the way, that the team had not seen before, which means that there's a certain medicine that needs to be stocked in our maternity units. So women are precious, and if men believe women are precious, the men would make better decisions about women, not just because it's 14th of February is 2 days to come. No, because the sort of things that women have to go through to give birth are extremely painful, and if all of us were to think about what they are going through, we would put in an effort. I know a mother who died after doing 9 ANCs. 9. And her twins. She left 2 twins. Twins, yes. And I bothered to buy the none, so I know what it means for a family. So what the president said is correct. And I have posed this question in all meetings. Which woman is this who is going to become the next statistic in your life? Thank you.
Thank you. Thank you. Thank you very much, Your Excellency. Of course, we do not want any women to be the statistics we are talking about. And thanks for the commitment to attend the meetings, and also for the other governors to attend these meetings. And I can see why you are honorary member 001. All of this lingo you have passed with flying colors. Dr. Serem, let me ask you from the Ministry of Health, from a policy point of view. Of course, the county governments have taken up the issue of Mpdsr, but what other systemic frameworks or activities and, actions are you taking from the Ministry of Health to make sure that, everyone is a champion, so that next time we're asking about who's an Mpdsr champion, then the whole room stands up? What are those things that the Ministry of Health is putting in place so that we are all on board, not just a pocket of us?
Thank you very much. From the Ministry of Health, being tasked with coming up with policies, review, standards, and guidelines. As in Mpdsr, for example, therefore, I think we have reviewed the guidelines, and this is as late as 2024, and indeed we have disseminated together with the reporting tools. This is making sure that the counties are sensitized and they're up to date on the guidelines and the reporting system. We've also, therefore, disseminated to all the counties in this country, and we have also gone ahead in sensitizing the healthcare workers and some of the community members on Mpdsr tools and guidelines. We emphasize the issues of governance in the issue of making sure that we have the committees, functional committees, all the way from the county level, because we have one at the national level. We also emphasize that we have all the counties have functional committees. So the guidance gives who should be in the committee and how often should they meet, how often or at what stage should they audit. So this is part of the work which we are doing from our end together with the counties. We are also in strengthening on Mpdsr operations system. We are coming up with Mpdsr action track. These together we are developing with the counties also to make sure that we emphasize and look at the response. What is it that healthcare workers, leaders should do in making sure that we fix the response aspect? Because that has been the weak challenge. The other one, we are also in the process of digitalizing the Mpdsr tools so that we go digital. And I think it's part of the digitalization process which is going on with the DHA agency. On the other hand, we've therefore also gone ahead for issues of sustainability, incorporating the training institutions and the academia. We have therefore been having a meeting with them to make sure that PERINATAL guidelines are incorporated into the training curriculum for both in both the colleges and the universities. And on the same note, we will also make sure that we come up with an annual report on Mpdsr for the country, so that in every county we know how we are tracking and how we are improving that. Thank you very much.
Thank you. Thank you. Let's give him a round of applause. Thank you for telling us what's happening. Let's go to the county, Dr. Osuri. You chair the Chief Officers County, that's technical. Are there inter-county collaborations? Because we are talking about, inter-county Mpdsr. Are there those collaborations, and how are they contributing to improvements in the referral systems between the counties, sharing any available commodities and, emergency responses?
Thank you, Dr. Koril. So I'll begin by saying that mothers, like Dr. Ganda said, mothers don't choose which county to get pregnant in or which one to give birth in. So our mothers do not know about boundaries in counties. And for that reason, it's very important, and I've said it before, that it's not good enough that one county is safe for mothers to give birth, and then in the next county, mothers are dying. This has to be a concerted effort. It starts all the way from MOH, Council of Governors. That's why I saw on Monday at the full council, there was a discussion about Mpdsr, so that mothers are safe in every county. And if you look at issues like blood and blood products, not every county has enough. And for that reason, we move blood from one county to the other to help the mothers that we have. But I would just want to emphasize on what the governor for Makueni has stated. Leadership is very important, and I think we've been speaking about Mpdsr from way in 2009 and 2010 with very little progress. But just across the country here in Uganda, there has been significant progress, and I want to laud everyone in this room that perhaps we are now getting it right by including leaders. If you look at our counties where we come from, a governor alone is not enough in an Mpdsr intervention. You need the county assembly as well. You need the people who draw the budgets. You need the people who make the budgets. You need the regional corporations and so on and so forth. So leadership, you cannot lead by absence. And we have seen it in many Mpdsr incidences where the presence of governors, the presence of chief officers and CECs has made a significant contribution and has saved so many lives. I can show you every single county that we have referred there and said we have not lost mothers for this period of time. The CEC is involved, the governor is involved, and everybody is involved. I can tell this audience, and I was telling Governor Mutula here, that I first heard him pronounce very easily Hit-Stable Kabetos in Cape Town. And I thought that maybe he had been grilled and coached about it. And I've since heard you say it severally, so I think maybe you might even know its mechanism of action. But it shows interest. It demonstrates interest, that he's interested in it. I mean, you can all attest that when he was speaking about these issues, he's not coached. He knows about what he's talking. He knows what he's referring to. He knows why mothers are dying. Since COG took us, Dr. Korir, since we went to Uganda in 2023, I have never missed an MPDSR meeting on a Tuesday. Every single week on Tuesday morning, I personally chair that meeting. And I don't chair it because there are not others who can chair, but I'm giving the leadership presence. We so many times blame doctors and blame nurses, but there's nothing a doctor can do if an ambulance has broken down. There's nothing a doctor can do if you've not fixed the road. There's nothing a doctor can do if there's no staff. So it begins with the leadership, and perhaps on MPDSR, what we need to emphasize, the skills are there, the staff are there, but what we need is a leadership presence. Thank you.
Thank you. Thank you very much, Dr. Osuri. Coming to you, Dr. Muthembo from Laikipia County. The three speakers ahead of you have emphasized on leadership being very key. How has leadership supported you in any way in Laikipia County, especially when you need to respond as a clinician, you need to have certain things in place. How has leadership supported, and what leadership are you providing yourself as the OBGY?
Okay. MPDSR is in the heart of Laikipia County, as you have seen also in the past, that we are really thinking about maternal health. And one of the things that we had, even from the leadership in Laikipia, they appointed a County MPDSR committee formally, and also they've been holding the MPDSR committee meetings. Through these committee meetings, we've been able to identify areas that need help, especially when it comes to our particular county, and our main areas are the delays. One of the things that we've been able to access now that the county is involved is the presence of heat-stable carbetocin, which has been made available in our main hospitals, and even our caffeine citrate and also CPAP machines, which we've received also from the Ministry of Health, which we are very, very grateful about. This all wouldn't have happened without our leadership. The other thing is, when it comes to our delays, and also in our area as obstetrician, gynecologists, and pediatricians in our county levels, we've been able to hold meetings with our communities. Maybe some of you have also seen us doing radio presentations to get to the grassroots, to let our communities know. Because our community in Laikipia, we have a lot of pastoralist community. And as you know, some of them, the delays come from the decision making. And it's not because they do not know that this is bad. They know, but what they don't know is that we have available resources for them to also use at their level to save their lives. So community engagement has been key in our area, where we've been able to reach as many women as possible. We're still doing it. We still have a lot of work because we have other challenges such as early child marriages, we have nutritional issues. All those, with our government, we're able to handle some of those issues. When it comes to our level, in the facility levels, training. Our leadership has been very, very good with us. We've worked together with other stakeholders to do training on emergency EMONC and also the comprehensive newborn. How we do it is we go to the grassroots, to the hospitals. We personally, even ask the gynaes, we go to our different hospitals and we train how to do emergency resuscitation and also to identify, particularly PPH and preeclampsia. Those two, as a county, we've decided to attack those two main causes of maternal death. Yeah, thank you.
Thank you. Thank you, Dr. Muthembo. Coming to Dina Haemba from Bungoma County. One of the principles of MPDSR is a no blame, no shame culture. What decisions have you had to make, as a county referral hospital, in making sure that you are able to address issues of negligence or any, issues that have arisen where there's a maternal or perinatal death without necessarily having punitive consequences to whatever the cause is?
First of all, we look at the leadership gaps in the facility. This is where the leadership fails to focus on the Mpdsr process, in that after that Mpdsr, maybe the action points are not taken care of. There's no seriousness. This includes the board members and the committees in the facility. And it affects the prevention of maternal and neonatal deaths in a way that it undermines the institutional process whereby budgeting of commodities is a problem, whereby staffs will improvise. We also have understaffing where junior staffs are left alone on duty, and they have a gap in making a decision, fail to recognize that there's a problem that can be acted on. It is only realized later when the mother has changed condition. It also leads to not reinforcing the proper protocols and standards, in that everything that we are doing is just improvising, and we are even normalizing the abnormalities. For example, we know the labor process, we are supposed to monitor a mother, but because of numbers, the mother will be there, deliver a mother, get a poorly scored baby, then you just say, mother came in second stage. That is not proper. We are normalizing the abnormalities. When we have the Mpdsr and negligence, we are supposed to separate learning and accountability. Mpdsr is all about the gaps that led to that outcome. Of course, the outcome is not only the bad outcome, we also discuss the near misses. Then in Mpdsr, we don't discuss a staff's behavior, and we don't discuss individuals. If there's negligence, we'll go to the root cause, root analysis, talk to the staff, find out where the problem is. Then after that, we will hand over the human resource, and it will take its own process using the Kenyan laid down laws. Thank you so much.
Thank you, Dina. And that point about normalizing the abnormality, so that's why this meeting is there, so that we aim to do best practice. Let me go to Kitui County. Christine, as the focal person for reproductive health in your county, what more can be done to strengthen support in health facilities in addressing issues, related to mothers and children?
Thank you, Dr. Korir, for that question. The fact that you have asked, what more can be done, means that we are doing a lot. But I want to emphasize on two areas, which if we come together and put more effort, we can strengthen support at the facility level. And one is capacity building, mentorship. Mentorship makes the healthcare workers become very competent, and they implement the activities with passion, and everything goes on well. And when it comes to mentorship, you as the obstetricians, gynecologists, since you are the experts, you are supposed to also go even down to the health facilities, to the dispensaries, do that mentorship, give them that expertise. So that is one point. And the other point is strengthening support supervision. You really need to go down all the way to the grassroots level and support the dispensaries. Like, for example, in Kitui County, I went for a support supervision at some point and found that 4NC was on a downward trend. And what did I do? Because we have 3 gadgets of point of care ultrasound, I mobilized the community health promoters so that when we go for outreaches, they say that there will be ultrasound services free of charge for all women who are pregnant. And I'm telling you, we got so many mothers coming for that outreach to get that ultrasound care for free. And that one, I'm sure when I go back, I will find that it has improved for the ANC and even all the way to the 8th ANC. And this one, I'm saying that since you are the experts, come and be at the center stage as obstetricians and gynecologists. Let's work together. When it comes to collaboration with partners, let this be county-led. Let the counties focus the partners, and then with that, we can have everyone working together. We don't duplicate activities, and by this, every shilling will count. Thank you so much.
Thank you, Christine. Then last but not least, as we are having these conversations, I'm asking myself, are we undermining the newborn, the little one, and almost treating the little one as a byproduct of the conversation? Dr. Mwasi.
Thank you so much for that question. So I'd like to applaud my obstetricians for the good work you do. You support the mother throughout pregnancy, even before conception. You try and help this mom carry her baby as much as possible to term. You manage the complications and prevent other complications from coming in. And I know your ultimate goal is for you to have a healthy mother and a healthy baby. So one of the ways of amplifying the newborn in this conversation is involving the neonatal team. Most of the time, we need to change our cultural, structural shift, our mindset, so that we don't think only of maternal care. We should think of the dyad, maternal and baby care, mother and baby care, so that we involve the pediatrician and neonatologist from the beginning. We have fetal maternal medicine now. As soon as you are able to see that there is risk, there are issues with this fetus, can we also involve the neonatal team so that we have counseling for the mother from the beginning? Let's work together. Let's plan for the delivery of this baby together so that you achieve your objectives and the mother also is able to achieve her objective of getting a healthy baby. So let's come together, have clinics together, counsel the mother together. We can have ward runs where we discuss, as you're seeing the mother, we're also discussing the expected fetal outcomes. That will help us in terms of planning even for delivery of this baby. For example, if we have high-risk mothers, like mothers with hypertension, mothers who have preterm labor, mothers who have diabetes, mothers who have babies who have intrauterine growth restriction, we could work together towards planning for delivery of this baby so that even as you focus on the mother, we have someone specifically focusing on this baby, making sure resuscitation equipments are ready to resuscitate this baby, making sure the team is skilled enough to do the right resuscitation for babies, and also having family-centered care so that the parents are totally involved throughout care from pregnancy to delivery and even afterwards. And that would help in increasing and improving our quality of care and better outcomes. Thank you very much.
Thank you very much. So making sure the baby is also at the center from the beginning. Your Excellency, we are speaking about leadership and governance being key to these conversations. How do we hold you, and by you, I mean governors, the people who decide the budget, be it a national, county, how do we hold you accountable so that we reach that 70 number by 2030?
That's a good question. I was in a meeting with the Council of Governors and the American government on an engagement which the country has signed in with the Trump administration. In that discussion, I didn't hear anything about this cause. And we have signed in into billions of shillings to treat matters which are not as serious as what we are discussing today. But nobody's asking those questions. I've seen KMPDU leadership here. Nobody has asked that question. The billions that we have signed in are all going to be issued and possibly stationed at Nairobi. The Center of Health in Kenya is not in Nairobi. the woman in Moyale, the woman in Tana River, the woman in Kilifi, the woman in Nairobi, the woman in Kakuma should receive the same treatment as the woman in Nairobi. We can only do so if we make this a national subject. When I hear the figures, and if the figures are correct, the figures of both maternal health, maternal deaths and neonatals are higher than road accidents per day. Yet that discussion does not sit well at a national level. The learning experience, we, for example, we have engaged, and I'm happy that Kilifi has engaged Proximi. When Proximi was giving us the technology for telemedicine, part of the equipment that came into Makueni, the taxes were higher than the cost of that equipment. Why is this important, good people, in terms of innovation? If we are going to scale up and move quickly, there is no time to think. We have to copy best practices and possibly copy and paste. Where people are doing well, let them learn remotely. We can use technology. We have become very advanced on sending money. We can do the same if it comes to these things. So the gynecologist who is doing something in Nairobi, the one who is doing something in Turkana, can train somebody else who is in Kilifi. It bothers me that we have only 11 experts on obstructive fistula. 11 in Kenya. 11 only. We did a camp with Professor Kihara. I saw women with gray hair have had obstructive fistula for 19 years. 20 years from Kiambu, others from Machakos and other places. These stories are extremely painful in a country that takes pride in having been independent for 60 years. They are painful experiences. Cost of implements, cost of innovation. Had we not piloted H-table carbetocin even before approval, and we did it, it was 2,700 a vial. It's now at 80. Now, it was 2,700. How many counties can afford to have incubators in all their facilities? They're expensive. So this subject and tying all these things together requires a very urgent conversation, and I hope that as we go along, we will invite other champions at the national leadership so that we can put this subject correctly. I sat in the Senate for 10 years and I never had this conversation. 10. We spoke about everything under the sun. We spoke until we were sweating. We sat until midnight. Nobody discussed mothers who are dying or neonatals for 10 years. Never. And I can assure you the National Assembly is discussing other things other than this issue. So can we take these conversations to counties? Sit into conversations in county to discuss these matters because they are important. And the half or 3/4 of the people in leadership in Kenya today are men. Get male champions to be the people at the forefront to discuss these matters. The taboo about discussing birth or men not going into theaters is an absurdity, if not ludicrous. I was in a hospital, and I've mentioned the 2 cases. And when I asked the mothers, as the father of this child who had a head surgery, come to see this child, the 2 mothers told me, no, the fathers have not come. I'm happy when we had a discussion with Professor Kihara, she came and trained my border leaders in Makueni about ANC. Because these people play a critical role. They are the people transporting these women to hospital and dispensaries. So somewhere in the conversation, when they're discussing about Sifuna, they can ask, have you gone for your ANC? When's the last time you went to see the doctor? Those things. Critical things like iron supplements are possibly the cause of preterm. Teenage mothers, 13% in Makueni, 18% in some counties, 20% in others. Children are giving birth to children. Friends, if you don't call this a crisis, I don't know what is. Thank you. Thank you.
Thank you very much. So we should ask the critical questions, get the male champions, and make sure, you know, these places of parliament, that these conversations land there. Thank you very much. I want to give 2 burning questions, only if they are burning, or comments, only if they are burning. Kigondu, are you sure you have a burning question? Or comment? And then there's a gentleman at the far back. I'll only take those 2. Make them very brief, in like 30 seconds or so. I'll just take those 2. The gentleman at the back and Kigondu, only if Kigondu's is burning. So allow me to start at the back and then I come to the president. Start with the gentleman at the back. Okay, Kigondu, you have the mic. 1 minute.
Yeah, so thank you very much. I think everyone has done very well, and we commend the Council of Governors for a job well done, County Mpdsr. We participate, and I think this is the best thing that has ever happened to this country in health for the last very many years, Asanteni. Our biggest, of course, the current conversation is on the impact of non-payment of all health services by the Social Health Authority. SHA is currently flawed and it is not paying, it is rejecting valid claims, and the biggest victims are the county governments. Yet you have talked around all these things, but when it comes to healthcare financing, no one is talking about the flawed nature of the Social Health Authority system perpetrated by the Digital Health Authority that is rejecting claims that are valid, and it is almost deliberate. I work in Kegumo. The Auditor General raised queries and said that one of our biggest threats is the 3 million shillings owed by SHA, and that was in 2025. It's now 4. The whole of Murang'a County has a SHA debt that is increasing of 206 million, and it's going up. The whole of Kenya in 1 year has 43 billion debt by SHA, and they keep claiming SHA is working. It's working for the people who are being forcing health providers to give free treatment. You, Makueni County Referral Hospital, are paying for that patient as SHA is eating the money. When we raise the question, we have a CS who tells us we are fraudulent. When we tell him to bring the fraud, he doesn't. He just keeps talking about fraud. Our biggest problem in maternal mortality today is SHA.
Thank you, Dr. Kigondu. Your Excellency, I'm sure you've taken note. Dr. Serem and Dr. Osuri, you can take that up. Oh, that's Dr. Sirengo. Go ahead, please.
Thank you. Maybe we need some light behind here. First, I would like to appreciate the conversations and the contribution from the presenters. It's great to hear from Governor 001 for Kogs sharing what he's doing in Makueni. That's great. Now, listening to the conversation, I don't think we can have Mpdsr conversations without blood.
Blood.
Without blood. I am in charge of blood at the moment, and I'm still at pains why I was not given a seat at the front. Yes, but when we listen to this conversation, it appears like we talk about blood at the moment we need it. We forget that we need to plan for it. We must, with intent, make sure that the people responsible for blood availability at the county level are part and parcel of the conversation at all times. A lot of times people think blood is free. Yes, it's free as a product, but there is a cost to it. Someone has to meet that cost. It costs money to get the supplies, the blood bank and stuff like that. It costs money to do a blood drive. It costs money to test. It costs money to store it and distribute. But a lot of times when we have this conversation about blood, we only remember it at the point that we need it. There must be deliberate attempt in every conversation to look at how blood is being collected, whether it's available, whether it's accessible, whether it's enough, so that we can save our mothers. Otherwise, we'll just keep talking about the same thing. Thank you.
Thank you very much, Dr. Sirengo, for reminding us of that. I'm sure the organizers of this conversation and the Inter-County Mpdsr have taken note of that. Allow me to give my panelists just 30 seconds each to give your closing remarks. Let me start with Dr. Serem, Dr. Osuri. Very, very briefly, please.
Thank you very much for this opportunity, and I want to take this opportunity to thank the gynecologists who are present here, the midwives, for their support in issues of Mpdsr and all in all, uplifting the maternal health in our country. Thank you.
Thank you, Dr. Muthembo.
Yes, I just want to talk to everyone here that us as doctors, we need to, when we see our patients, we really need to see them. See them, look at that girl who's from the grassroots, what are her risks? Because some of these things, when it comes to PPH, preeclampsia, preterm labor, they come from the diet, they come from how they live, it comes from GBV and all that. So really listen to what they are telling you. Listen, listen, listen. Thank you.
Thank you. Christine, very briefly.
Yeah, my parting shot is that with committed leadership and partnerships, we can reduce preventable maternal and newborn deaths. Thank you.
Thank you. Dr. Mwasi?
My parting shot is let us embrace mother-baby dyad, let us work as a team, and we will definitely achieve better quality and better outcomes for both our mothers and their children. Thank you.
Thank you. Dina?
I would like to appeal to everybody who is in the house today. When you are in that facility where you are working, you see a pregnant mother coming in, walking. Keep in mind, those 2 legs she's using to walk, one is in the grave, one is on earth. This one in the grave can drag this other one to follow. Let us cling on those feet. Does not mean that we hold the mother. It means mentorship, skills. Let us use data. Right from the national level, it speaks and it does not lie. It will help us to address all the gaps that we have. Finally, let us not accept preventable maternal and neonatal deaths to occur. Thank you.
Thank you. Dr. Osuri? Thank you, Dina.
Thank you very much. I would begin by just saying that one of the most significant threats right now to maternal mortality and child mortality is not even PPH, but it is unpredictable health financing. In the counties where we offer these services, counties are straining to finance healthcare. And if we continue burying our heads in the sand and saying SHA is working as it should, then we are perhaps in the wrong place. A conversation needs to be had, very difficult conversation. That we cannot bar mothers from level 2 and level 3 from delivering. Mothers don't know about levels. They know about a facility. And they expect that when they go to that facility, they should get help. They don't know about SHA is not working here or not working there. The other thing is what Dr. Sirengo has talked about, blood, which is very, very important to us. When we talk about PPH, we are not talking about mothers bleeding juice or water. We are talking about them bleeding blood. And we need to take deliberate steps. And I think as COG and also the counties, we have had that. And we will take that matter up as leadership of the caucuses together with COG and indeed the Council of Governors to talk about blood. The governor here yesterday, on Monday, talked to the US government very boldly and the CS, Honorable Duale, about blood. And we didn't coach you, Governor, but you spoke very firmly. And we need to do something about that. I want to finish by saying that all of us in this room and those of us not here but are interested in this space, the death of mothers and newborns has to be abnormal. Thank you.
Thank you very much. Governor, I want to give you the final say.
Thank you. Thank you for the opportunity for us to speak. We must continue having these conversations. I agree with Dr. Kigondu. I agree with Dr. Serem about blood. I spoke about it. When I spoke about SHA, when I was the chair of legal affairs, people thought I was crazy, but it has come to pass. When I spoke about debt in the Senate, people thought I was crazy. It has come to pass. You have the opportunity of changing leadership, because if we don't think about this, it's going to hurt us. Unfortunately, the people who are affected the most by SHA are not seated in this room. The people who are here can afford insurance. The people who cannot afford insurance don't know where to go. So when we tell them it's not working, what are they supposed to do? What is that woman who is paying 2,000-3,000 shillings supposed to do? What is she supposed to do? So although I agree, Dr. Kigondu, please think about the bottom of the pyramid. Makueni has set aside 90 million shillings to take care of vulnerable families, because I know what that means. If we don't set aside resources, I will still pay for it. Anyway, it will still come. In Arambe for medical care or death. So you choose. So the poor Kenyans who are not in this air-conditioned room don't have a place to go. And they are the majority. So I've stopped speaking from the point of privilege, where I can say very lofty statements. I speak from the point where I can understand the point of need of Mama Mwikali and Mutiso and Ishmael, who don't have a country to go to, any other place to go to, and don't have an alternative of how they can get their care. We must make SHA work. We have no option. Otherwise, you are going to have a crisis. Thank you.
Thank you. Thank you very much, Your Excellency, for those remarks. We've come to the tail end of our panel discussion. I hope it has been inspirational. I hope it's been challenging at the same time. I hope we have all picked a lot to go and implement in our various places of work. Now allow me to welcome Dr. Kireki, who has some certificates to issue, and we'll do a few gifts to our panelists, and then we'll close it.
Thank you very much. And I'm standing between you and the lunch. We have 3 certificates to give. Your Excellency, do you mind if I ask you if you can present them? And one of them is to Honorable Her Excellency Gladys Wanga. So maybe Dr. Usuri, you can take for her. We have awarded her honorary member. Honorary member of Kenyan Obstetrical and Gynecological Society. Maybe we can move this way a bit so that we can see there, 50th. There.
Who is number 3?
Number 3 ni His Excellency Irongo Kangata. Na hiyo certificate yake ilichukuliwa na Dr. Kigondu, I think. One of his, yes. Thank you so much. The other one we want to give is to Rosemary Kihoto. And this is in recognition of your outstanding partnership and commitment to advancing maternal and reproductive health in Kenya, and for your continued support in strengthening health systems, expanding access to quality care, and improving outcomes for women and families. Thank you very much. The last one is Dr. Evelyn Ndinda Mudhoka. I don't know whether she's still around. Dr. Evelyn Ndinda. Dr. Evelyn Ndinda has completed the HIFU ablation training. HIFU is high-intensity frequency ultrasound for treating fibroids, non-invasive. So thereby qualifying for the certificate on the 28th of January 2026, and this training enables her to practice HIFU treatment independently. Thank you very much, Dr. Ndinda. And then lastly, the last one. The last one is Dr. Saudia Mohammed and Dr. Edgar Gulavi. I don't know whether any of them is here. Saudia and Dr. Gulavi. These ones have actually got a 2-week scholarship, fully paid by one of our sponsors, to go for an observership in IVF. So Dr. Gulavi is here. Msalimie tu, lakini nini itakuja baadaye. Thank you. Thank you so much. Kennedy, where are you?
Then the last bit, Professor Kihara, I'd ask you kindly issue these gifts to Your Excellency and the rest of the panelists. So we'll start with His Excellency. I'm almost saying Dr. Mutula Kilonzo. Allow me to say it. Your Excellency, thank you for gracing this conversation. Thank you for having Mpdsr as a key conversation and as a key aspect of Makueni County. Thank you very much. Don't leave yet, because I'll want us to take photos with the rest of the panelists. Dr. Serem, you're next. Dr. Osuri, Dr. Muthemba, you can come in that order. Dr. Serem, thank you for your time. Let's appreciate Dr. Osuri, harakisha mguu kidogo. Dr. Muthemba, Christine, Dina, Dr. Mwas. Please, thank you for your time. Thank you for contributing to the conversations. Thank you very much for your time. Then Dr. Muthemba, msiende mbali sana tupige picha. Dina. Christine Sami from Kitui County. And Dr. Mwasi, the pediatrician on the panel. Let's appreciate them and give them a warm round of applause. And then